Live now, so welcome all to the second session of day 2 of Health for Inclusive Growth. Health Tech, the theme is Tech for Saving Lives, and this session will focus on technology empowering paramedics, and everybody will agree with us how important the role of paramedics is in healthcare delivery. So this session is being chaired by Dr. Sanjay Kapoor, Professor and Consultant, Surgical Oncology, Deputy Director, Medical, Tata Medical Center. And we have with us as speakers, Dr. Rahul Singh Sardar, Director, ICATT Air Ambulance, Mr. Arindam Bhattacharya, Faculty Member, George Telegraph, Sister Shanta Shahu, General Manager, Nursing Services, AMRI, Mukundapur, Dr. Devi Prasad Samadda, Director, Medical Affairs, Ruby General Hospital, Dr. Samratrao, in charge, Critical Care Medicine, Techno India Dama Hospital, Mr. Bharat Sharma, Founder, Dakshas. So with this, I would request Dr. Sanjay Kapoor to please take the session forward.
Thank you, madam. And on behalf of all the panelists, I would like to thank the Bengal Commerce Chambers to take this pertinent issue of training the paramedicals. I welcome all the panelists and all the delegates who are here on the virtual platform. The healthcare service has got various pillars, and I personally believe that there are 4 major pillars that contribute to the healthcare: the doctors, the nursing and the paramedicals, the equipments, and the infrastructure. Now, of these, all 4 are equally important. But of lately, over the last 2 decades, with the technology coming in with this absolutely unimaginable speed and in an unimaginable way, the requirement of our medical knowledge and the healthcare services to become digitalized and to become technical savvy has become very, very important. And here, between the doctors who use the equipment come the paramedicals, and their role becomes absolutely mandatory. So I am honored, in fact, to have such eminent panelists with us, and I'm sure they will share some very, very important issues which will be helpful to each and all. The doctors do their role, be it in the labs, be in the OT, in the robotics, and the paramedicals have to ensure 2 things: the functioning of the equipment, the recording of the data, the monitoring of the patient, and innumerable things where the digitalization, the technology, and data collection, everything comes into. So let us hear from each one of you. So I would request each one of you to introduce yourself and give just a small brief of your work, maybe in a minute or so, before we go in for the question answers or the main presentations from each one. So, Dr. Rahul.
Good afternoon, everyone. And I'm Dr. Rahul Singh Sardar. I'm an intensivist, anesthetist and intensivist trained in UK. I was did all my postgraduate training there and relocated to India to start my own air ambulance service. So coming from a system where a mature paramedical service is in practice, and coming to India and adapting to the circumstances here and trying to make the best of it. And so that's going to be the core of my presentation. Yeah.
Okay. Thank you. Thank you very much. Mr. Arindam Bhattacharya.
Good afternoon, sir. Good afternoon, all of you. I'm Arindam Bhattacharya. I have completed my master's from Calcutta University, securing first class. And I'm also a teacher of an undergraduate college, and I'm also the guest lecturer of George Telegraph Paramedical Institution. Thank you.
Madam Santa Sahu, has she joined?
Yes,
Not.
sir.
Yeah.
Am I
please.
audible?
Yes, yes, ma'am. Yes. Yeah.
Yeah. Good afternoon, everyone. And it is really, I'm humbled to be the part of this discussion. And I love this topic of tech saving lives because we all need to be very tech savvy. And myself, I am Shanta Rani Sahu. I'm right now heading the nursing GM nursing services for AMRI Mukundapur. I have done my masters, and I have also done my NABH courses. And the first course that was done for JCI in Delhi for India. So
That's
I
interesting.
am contributing my expertise for improving nursing
Yeah.
and patient satisfaction. Thank you.
Dr. Samratrao.
Good afternoon, sir. Good afternoon,
Yeah.
everyone. I'm Dr. Samratrao. I'm an internist and intensivist at Technoderma Hospital. We are mostly handling critically ill patients on a 24/7 basis over here. So this topic is quite relevant to me because patient transport, critically ill patient transport is very dicey, and it's if we can implement technology into it to get it more smoother, it will help the patients and also us in the long run.
Thank you. Dr. Devi Prasad, please.
Yeah, good afternoon to all, and specifically the viewers who are of this virtual platform. So I'm having professional background is anesthesia and critical care. I also have got administrative background. I am presently director of medical affairs in Regional Hospital, and also a teacher for FNB critical care, DNB critical care, and DNB anesthesia. So, as considering my background as an anesthesiologist and intensivist, we all understand the immense importance of all the paramedical staff and how do they act as a bridge between the patients and patients' relatives and the care providers, the doctors. So they are basically the backbone of any institution because the clinicians remain for very less period with the patients, but the paramedics, they spend most of the time with the patient and their relatives. So their role is immensely important, and the technology has further enhanced their role. So I hope during this discussion we'll be talking and discussing that in detail with all the speakers' participation. Thank you.
Thank you. Mr. Bharat Sharma.
Thank you, sir. I'm an orthopedic surgeon and I specialize in keyhole joint surgery. And I'm here to thank all the paramedics who have trained me over the years. I remember as a young intern, when I first went for my internship to the emergency room, my unit had handed me to the nurse and said, make sure this boy doesn't make any mistakes. From there to our OT technician, when I went to orthopedic residency, and we all learned how to position patients for surgery from him. From the specialist knee replacement nurse with whom I started my fellowship, and I borrowed her notes to understand how knee replacement is done. And even now, the work I'm doing towards universal care is all based on paramedics. So I'm immensely grateful to their fraternity for having me help me achieve whatever I have achieved during my profession. Thank you.
Thank you. Thank you very much. And I would especially like to thank you and agree with you for what you said, because I am from the army background and graduate and postgraduate from AFMC. And in the armed forces, those days, we used to have these Anglo-Indian matrons in the OT. And they were stricter than your moms. And at the same time, they would feed you also. But from the knotting to cleaning to the stitching, all of that we have learned from those matrons. And same goes from the OT technicians and other paramedicals, from the catheterization to the blood sampling, Ryle's tube, all these things have come. So that's why I always keep them at par with the other four pillars of the healthcare service, because they are of utmost importance. So, and we have to give them not only the kind of training, but above all, we have to give them that respect and identity where they consider themselves as a part of a healthcare system and not just an employee in a hospital or a staff in a particular department. So with these short introductions, we would now go into the bigger things. So let us first go on our topics, say a max of 4 to 5 minutes each. So I would like to start with Mr. Arindam Bhattacharya, who would like to talk and tell us about the technological advancements in modern paramedical sciences and the new role of paramedicals. So Mr. Arindam.
Okay, thank you, sir. Respected chairperson, honorable guests, speakers, and members. It is a great privilege for me to deliver a lecture among you as an invited speaker in this Health and Economic Summit of Bengal Chamber of Commerce and Industry. The Bengal Chamber of Commerce and Industry is one of the oldest non-government advocacy group, played a pivotal role as a leader steering the evolution of commerce and industry in India. This session is headed as Technology Empowering Paramedics, and my lecture topic is Technological Advancement in Modern Paramedical Science and a New Role of Paramedics. Paramedical science is a science emerged as an important branch of medical science that help the doctor's specialized area and facilities for better diagnosis, treatments, and therapy. Paramedic is a healthcare professional whose primary role is to provide advanced emergency medical care for critical and emergent patients. But nowadays, role of the paramedics extended from the critical or emergent patients to the normal patients also. The term paramedic is usually used in reference to a professional that manages pre-hospital emergencies. The quote-unquote para in this case is perhaps a somewhat outdated referee to someone who assists a medical professional. Although this isn't really true today, as basically all paramedics have professional training and it isn't uncommon for them to be licensed themselves. Many countries like Sweden strive to have an ambulance crew consisting of one ambulance medic or driver and one licensed nurse with subspecialization in pre-hospital care. A paramedic in the civilian United States is the highest license level of emergency medical technician, that is EMT. They often refer to them as medics as a shorter version of their title. So instead of looking for a paramedic intercept on an emergency call, they are more likely to call for a medic backup. In the US Army, a medic is a soldier whose primary duty is first aid on the battlefield. They usually serve in air medevac units and stabilize wounded soldiers and transport them to field hospitals. But in India, paramedic is an umbrella term which includes all the technicians related to phlebotomy, laboratory, operation theater, cath lab, radiology, critical care, physiotherapy, air ambulance operation. The deaths take place in roads or in cardiac arrest or in snake bite mortality in the world as well as India are not very less. These highlight the need for proper emergency medical services that can be accessed from any location. The last one massively important solution is the adoption and deployment of technology to support enhanced EMS performance across the whole continuum of care. For a rapidly increasing and aging population in the country, technology can go a long way in solving some of the complex and prevalent problems in EMS. In modern times, every technicians of different fields use multiple different technologies in their profession. Paramedics are not at all exceptions. In every part of paramedical science, technologies are used enormously. The last 30 years have seen an explosion in technological innovation in almost all parts of society, and the scientific laboratory is no exception. Technology has not only been at the forefront of exciting breakthroughs in the fields of medicine and many other sectors, but it has also helped to streamline existing practices and optimize efficiency. In laboratory technology, manual systems are outdated, They are replaced by totally automatic systems controlled by information technology like auto analyzer. It requires less sample, less time, give high performance and accurate results. Medical and clinical laboratory technicians use microscopes, cell counters, and other sophisticated lab equipments. The computerized instruments and automated equipment can perform a number of tests simultaneously. Laboratory automated and manual processes occur in 3 stages. The first stage is the pre-analytic stage. This includes choosing the test, placing the order, preparing the patient, collecting the specimen, transporting the specimen, any specimen preparation work, and daily quality control. The second stage is the analytic stage. This involves actual testing of the specimen and all routine procedures up to result reporting. And the third stage is the post-analytic stage. This is concerned primarily with forwarding results to the appropriate department or physician and routine daily maintenance and shutdown. There are many opportunities to automate pre-analytic processes. For instance, specimen containers can be pre-labeled with barcodes that link specimens to identifying electronic information. The container may also contain substances that automatically prepare the sample for processing. There has been progress with optical character recognition hardware and software that can read the labels. Test tubes may eventually have computer chips embedded in the stopper. Technology to automate many of the processes for olicot or specimen preparation, sample quality testing, specimen transport, and handling, test ordering over the internet may increase efficiency and reduce administrative errors during specimen collection and processing. In fact, scientists Fielder and Wilkinson once said machines eventually may draw blood specimens and robots may transport specimen from hospitalized patients to the hospital laboratory. That will be our future. In most laboratory settings, the analytic stage of testing is more automated. Beginning in the 1960s, several rounds of sophisticated automation resulted in multi-analyzers, which are multi-channel instruments that measure many different analytes. Automative technology also allows groups of tests called panels or profiles to be run on the same sample. A similar evolution occurred in the hematology laboratory also, where the counting of different types of blood cells is consolidated and expanded to include automated differentials on the same instrument. Over the past 20 years, the post-analytic phase has become more automated. In the 1980s, test results were often transferred by courier or mail. In the 1990s, they were sometimes conveyed over the telephone or via fax. Today, in some laboratories, the completed results are automatically forwarded to the appropriate area of the hospital or physician office electronically through the use of printers. And billing and utilization report generation is computerized. Electronic systems may also manage specimen transportation, storage, and disposal. 5 technologies which will have the greatest impact on the practice of laboratory medicine during the next decade, including molecular diagnostics, near patient testing, image analysis, robotics, and information management. In the operation theater, much more technology is now widely used. Nowadays, operation theaters are equipped with a range of different recording devices, including laparoscopic kit, light handle cameras, and wide-angle cameras, and microphones. There is an ongoing migration from invasive to less invasive and even non-invasive procedures. Minimally invasive surgery, image-guided procedures, robotic surgery, and telesurgery continue to replace the traditional surgical procedures. Single incision laparoscopic surgery and natural orifice transluminal endoscopic surgery techniques are continuing to evolve and transform laparoscopic procedures. Procedures once requiring general anesthesia can now be performed with image-guided vascular access technologies and other endoscopic access techniques. tumor ablation instead of
Mr. Arindam?
resection.
Yeah.
Yes, sir.
Yeah. May we end at now and carry forward later in the second round?
Okay.
Yeah.
Okay.
So thank you very much to
Just
highlight the evolution of technology in the paramedical and moreover in the total healthcare system. And I absolutely agree with you that there were times where we used to collect separate samples for each test, which would be at times 10 bottles and 15 bottles, which was really cumbersome. And now with just one sample, a whole panel and hundreds of tests can be done at a short time in a neater manner, safer manner, and at the same time, the data is collected, analyzed, and the report generated and sent via SMS or via email to the concerned things. Thank you very much for your lecture, and we shall get back to you. I will now request Dr. Devi Prasad to kindly tell his views on the technology in the paramedicals.
Okay, thank you, Dr. Sanjay. So basically, why are we giving so much of importance? Though we know that the paramedics are very important, which includes the whole group, the nurses, the technician, the therapist, everyone who are actually between the patient and the doctors, who are helping in giving the need-based treatment to the patients. So there is, if we go by the statistics, there is dearth of human means healthcare resources. The manpower deficiency is there. That is immense at global level. And if we go by the WHO statistics 2016, then approximately 174 lakhs healthcare workers are deficient. They are needed, which includes 26 doctors and more than 90 lakhs nurses. The situation is still worse in India, I will say, because this is the second most populous country now. By 2027, we are going to be number 1. And we have about 57 lakhs doctors deficiency, around the healthcare workers deficiency, 11.6 lakhs deficiency of doctors, and around 23.4 lakh deficiency of nurses. The threshold that is advocated by WHO is 44.5 healthcare worker per 10,000 population. And if we go by the Indian statistics, it is only 4.4. So there is a lot of need of healthcare workers, which includes the doctors, but more so the paramedical staff, which are playing very, very important role in delivering the treatment, monitoring the patients, and carrying out different kind of orders. Niti Aayog very rightly has planned that by 22-23 they will be adding 15 lakhs more healthcare workers, and to achieve the WHO threshold of 44.5 per 10,000 population will be needing around 18 lakh doctors in future by 2030. So there is immense gap. Now when there is so much of dearth of manpower, skilled manpower, how do we bridge this gap and can maintain the adequacy of treatment to the patients? And it's not only patients in the hospital. The COVID in the recent past has taught us and given us lesson that there is dearth of hospital beds. Chronic patients are there who are suffering from chronic illness. They are at home, and instead of reactive patient care, we should be giving them preventive, proactive health care. How can we achieve that? Who will be providing this kind of care? If you see the rural and urban deployment of healthcare workers, then there is again a great disparity. Though the healthcare requirement is almost the same, maybe more, and that we are not able to meet. So here the healthcare workers, the paramedical staff will play immense role in bridging this gap, in providing this kind of therapy. Now there is dearth of the paramedical staff also. How will that be addressed, and how do we maintain the adequacy of treatment? So there this technology and advancement in technology plays very, very important role. and where actually the devices that had come, where we wear them, those devices which come in contact with the patient's body and surface and automatically monitor the patient's vital signs, and there are devices which do not come in contact with the patient's system, body, and then they monitor the patient. So I think the technology is going to help us in future to prevent or to address the gap that is existing in providing the care, because the resources, the human resources are not there. So this technology will actually be helping us and helping the paramedics ultimately to ensure that adequacy of treatment is there, rationalized treatment is being given, and rationalized treatment is being given at a rationalized cost also. So this is basically how do we make the whole thing available at the doorsteps of the patient instead of only depending on the hospital and hospital beds. So here the paramedical staff who are present in the hospital, the paramedical staff who are present in the community, they are going to the patient's home, to the rural area, to different regional regions where they will be offering this service with the help of technology, where the doctors and consultants, they will be actually guiding them, and with the help of this technological advancement, we will be giving a higher level of care to all the needies. So I will stop, conclude here. I will take the next question and elaborate further when Dr. Sanjay gives me the opportunity to do so.
Thank you very much, Dr. Devi. You brought out two very pertinent issues. One is the training of the paramedicals, and secondly, the gap in the healthcare providers. Now, training there earlier used to be in the form of various courses. When we were very young doctors, St. John's Ambulance used to run these first aid courses. And these first aid courses in the army, we would have it run for everybody, not only those from the medical side, but even the normal soldiers were trained. And we would also give it in schools and in colleges so that the basic first aid is available to everybody. So hence there are two things. One, it is very, very important that we revive the training in first aid to all the population across the country. And this should become a part of the curriculum where there should be trained bodies which can go and do it at those places, whether it is a school, whether it is a workplace. So like we have nowadays the art of living and the fitness lectures, we should also introduce the first aid at all levels, where the basic first aid in a day capsule with 8 or 10 lectures can be taken for all the people. One question has been brought to us, that how can India fight this deficiency and make up and produce more paramedicals as compared to the Western countries. Now, over the last 10 years, definitely a vast steps have been taken, and a lot of institutes have been opened, a lot of vacancies have been increased, and a lot of vacancies even in the government hospitals have increased for the nurses and the paramedicals. One thing which I see in the I've seen throughout in my military hospitals and now even at the Tata Medical Center, that we at the hospital itself are training the paramedicals. So you do not need a duplication of such. So there is a building, there is a ward, there are departments, there are doctors, and there are other required facilities where patient care is being taken. At the same time, the paramedicals are also being trained, not only for the training, but with a proper diploma and a degree. So besides concentrating on training of doctors only for graduation and post-graduation, we should ensure that most of the big institutes or any institute which is, say, 50 bedded above should be granted the permission to take paramedicals in the lab, in the OT, in the radiology department, and those bigger departments if you have super specialized centers, and 2 years courses where you get a diploma and a 3-year where you can do further. And that is one way by which India can create more seats without creating training institutes. So that is something we all should look forward to, and the government should also give, and the sanctioning authorities, permission to the institutes, and the institutes should be willing to train the paramedicals within the same campus. So that will be very helpful, and that will not have any additional cost on any establishment. I would now request Mr. Bharat Sharma to give his views on clinical decision and the support system.
Thank you, Dr. Kapoor. So thank you for giving me this opportunity to share some of the work that we have done with the paramedical system in India. And I would like to split this into 4 stories that we have experienced. So when we started working in the non-profit sector to ensure that the marginalized population are not denied healthcare, we realized that the problem is not that we don't have resources. The problem is that we are not utilizing those resources in the most efficient manner, and we are not unlocking everybody's unused capacity. So over a period of 2 years, while we were running our clinics, we realized that there are about approximately 90% of our decisions were repetitive. And we were collecting the same data, and we were producing the same decisions. So we packaged this into a paramedic training module, wherein now the first point of contact in our clinical system is the paramedic, either a nurse or a physiotherapist, who help collect all the patient data required very diligently. This is put into a portal that has been made by the organization. This portal is then able to run the specialist logics and generate a case summary and a provisional prescription, which is then escalated to a physician. So in this manner, when the patient presents to the physician, there is actually a case summary which is already ready. There is a provisional prescription that's already done. And then the physician can very efficiently look at the patient, compare the notes, edit that prescription, and release it. And 90% of our patients we are able to manage in the general practitioner level. The 2 to 5% of patients who have red flags are then escalated by the GP to the specialist within the same session. And the specialist is able to save 80% of their consultation time because it's already gone through a paramedic, the data is available, the prescription is available, and it's a couple of minutes of decision that they need to provide. In this fashion, we were able to bring down the cost of primary healthcare to 16% of what it exists today. And we were able to treat around 43,000 patients in this fashion. So what we have seen is a breakdown of barriers. We do not work in the silo of a paramedic, general practitioner, specialist. We're all working together. And we have a single integrated patient assessment. So the assessment of the patient is common, done by the paramedic, and the rest of the levels just add a few finer points. Now, coming to the next story that I would like to share with you, we started working in non-profit old age homes where we were going to provide clinical service, but we realized that the problem is not medical care. There are bedridden, abandoned elderly, and there's nobody to take care of them. So again, we reached out to the paramedic pool. We were able to connect to general duty assistants from the National Skill Development Corporation. And we were able to post 2 of them each in these non-profit old age homes. And we saw the rapid increase in the nutrition and the hygiene level of the elderly. And their overall health quality improved. We were not required. So we had to do nothing. Then we also noticed that there were a huge number of falls in this elderly population. And that's a burden that no health system can bear. Yes. So once again, we upskill the paramedics, the physiotherapists, the nurse assistants on how to screen the elderly for fall risk, how to identify the elderly who are moderate or high risk of falls. And after that assessment was done, risk factors were identified. We would rope the physicians, neurologists, cardiologists, orthopedicians to address specific factors. Over a period of 9 months, we were able to screen 900 elderly living in these destitute homes and ensure that there were no falls. Then we were hit by COVID, and that's my third story. So we offered all these general duty assistants. This is COVID first wave. Nobody knows what's going to happen. We heard horror stories from the Western world of what's happening in old age homes. Do you want to go back to your village? And I was so encouraged by their response that none of them left those elderly, none of them left those old age homes. They stayed put, and across, I think, 68 old age homes, 4,500 elderly during the first wave, we were able to ensure that no elderly got infected with COVID. The paramedics were able to upskill through remote training. They were able to upskill themselves in the use of PPEs, in the use of isolation. All this could happen remotely, and they delivered a perfect result. Now, the last story that we are trying to bridge here is a lot of these paramedics, especially the general duty assistants cadre that I'm talking about. So we have around 1.75 lakh general duty assistants in the country. They've been trained by NSDC. And the unique fact is most of them want to go back to their villages. They don't want to stay in the cities. After a year or two, a lot of them actually return to their village, and they don't have health sector work in their villages. Now imagine a scenario of India where we hammer so much that we don't have healthcare in the village, and you have this huge cadre who has been trained, who has hospital experience from the urban areas, now has moved to the village and they don't have work. So we are now trying to revive this cadre in the village through technology platforms, connecting them to remote healthcare delivery systems so that they can deliver healthcare to rural areas. I'll stop here. Thank you for this opportunity.
Thank you very much, Mr. Bharat. Very, very encouraging short stories, which mean a lot and which can be taken ahead to benefit our healthcare system a lot. And relating to these, I already said earlier that it is the need of the hour to involve the general population in healthcare. And the least they can do is to be trained in first aid, where they can take care of themselves and their near ones, and at the site of the accident, maybe on the road, at the workplace, or at that. So every organization should ensure that their people undergo training in first aid, including their families of their workers and employees, at least once a year. A lot of the burden of the healthcare we are shifting to the others. So like the healthcare, the HCAs, the healthcare assistants, who are not fully nursing people, but if they are trained and brought into a stream, they can do other work, simpler work, like helping the patient, giving a sponge bath, or making them walk, and the basics, which will relieve the nursing staff from these mundane jobs and give them time to give more attention to their real nursing role. Now, one question that has come is that technology may reduce dependence on the doctors, empowering the paramedical professionals. Now, this is a very, very important thing and a very, very important contribution of technology and advancement that we are seeing in our day-to-day lives. All of us remember as young children and otherwise also going to the ophthalmologist always for an eye check. And even now in the big eye centers, this work is being done by the optometrists. So the training of the paramedicals in a lot of fields, in fact, in all the fields, has decreased a lot of burden on the doctors. We have now in the lab assistants, the machines are so well automated that not every test needs to be tested by a pathologist, except for, of course, the tests which are the modern tests or the slides or the cytology. But the preparation and the basic tests, because of the training and because of the advancement in the technology, these paramedicals have contributed significantly in taking away the load from the doctors. Now, technology and the geriatrics patients definitely is a challenge, because many of the patients are not tech savvy. But a lot of lately, last few years and more so during the pandemics, lot of apps have been created and a lot of people have created the thing of teleconsultation and telemedicine. And in this case, the people can approach the elderly even at their home place and help them out or provide them solutions on their simple mobile phones. Majority of the people houses do have a simple mobile. So on apps we can do, and many a times the leave alone the simple advices, but even the transport of ECGs, the transport of prescriptions, and of course the orders of medicine, all these have gone through the apps to the elderly, and which go to a long way to comforting them. Yes, as Dr. Bharat has just told us, would you like to say, Dr. Bharat?
Yeah. Sure. So recently we have now launched a web-based app which allows any paramedic to quickly enter data points about an elderly and instantly find out the fall risk of that elderly. It's categorized into low, moderate, and severe fall risk, and they are able to then take simple measures to ensure that the elderly doesn't fall and coordinate their fall risk mitigation through multi-specialties. So I think technology can be an immense empowerment.
Yeah. And patient safety, as you brought out the reason of the fall, patient safety today has become very, very important. And this safety does not include only the treatment safety, but the safety of the entire experience of the patient within the campus of the hospital and otherwise for chronic patients in their home. So this is the aspect where the paramedicals are coming to a very, very great help. And I'm sure this will be taken ahead in a great manner. Now, may I request Madam Shanta Sahu to please tell us her views, especially regarding the nursing care and technology, how it has helped the nursing care in the present time.
Thank you, sir, for the opportunity. And I also take this opportunity to thank BCC&I for this for including me into this, and so that in the open forum at least we will be able to talk about the nursing contribution into it, and what nursing upgradation is required, de-skilling and reskilling of nurses is required to to make them tech savvy. So I take this opportunity to highlight that this pandemic has actually opened our eyes that we need to be more more tech savvy to reach out to, as rightly stated by Dr. Devi, rightly stated by Dr. Bharat, to reach out to more people in the community and to reach out to our doctors when they are not present in situ with the patients. So that the first and most important thing that our information is getting overloaded. So we need to declutter our information with the help of technology, which helps it to give proper cohorted information to our consultants, to our doctors, to our patients, to our patient relatives also specifically. So then this is where we come to nursing, where they can do electronic health recording, which is very important. For this, first and foremost, it is to all of us is that our training has to be changed. We have to reschedule our training process of the nurses, where digitalization, data information, data analysis has to be taught to them apart from the regular training that we give to them. Why is it that required? Because it is through nursing documentation that they are 24/7 with the patient, that we get actual data about the patient or our customer, I can say. Now this customer digitalization, how it can be done, that we already discussed about a barcoding of their patient's identification band. That can be a high-tech band where every nursing record that is done is digitalized, and the main consultant gets all the information update when the nurses record it in the patient's data in the system. It is connected with the barcode, and the doctor also gets all the updates automatically. So the information, passing on of the information is in such a short time that the patient care is zero lapse. So it is a seamless patient care that happens. Then this patient this leads to enhanced nursing care, quality of the patient. For this information, in this standard, what we can do, we cohort all the information for reference, for treatment, for education, and for research. This is one part. The other part is the simulation based training that I always love to do it, which was actually there in Manipal colleges, which I saw in basically back in West Bengal. We have not started the reach out to clinical enhancement of the training case-based simulators. Patient is crashing, where you don't have to do it on which are now advanced mannequins, not lifeless mannequins, so that the response time of a nurse can be assessed spontaneously. No acting. It's a role play which is very live. This will give them the adequate response by doing the mock drills. So we get simulation based training. Next, life-like situations for disaster management, which is very important. When the ER is, all of a sudden we get 10 to 20 patients in the ER after a trauma, how they will handle. So this response time, because this response time enhances both our EMT, the emergency technicians who are there, critical care technicians who are there, to respond adequately, treat adequately, and do their documentation adequately for the entire role play. With this, I would like to say that during the pandemics, with the help of our CEO, Sir, Mr. Rupuk Borua, we had a robot going towards our patient, because initially there was so much of fear of close contact. So the robots used to go, and we could talk to the patient, with the patient relatives, and the patient could also verbalize and communicate with the consultants through the robot only, when the robot went from one place to another. And of course, right now, AMRI's entire information of the patient's investigations, the packs that is admitted, it is done, and it goes directly to the consultant immediately. This simulation-based practices and training is very important to be inculcated. Why this forum I'm taking is that here we can think, and the nursing leaders out there can think and inculcate these trainings within the course curriculum where in-service education is going on. This will help fasten the nursing response time, which is a very, very, very important aspect when we come to.
Thank you, sister. Thank you very much, madam.
And very effectively, I admired fall risk assessment. Very important. Healthcare-based accidents to happen. Thank you.
Yeah. Thank you very much, madam, for highlighting these issues. And definitely, the specific things may not be trained, but every nurse should be trained in computers. In their training when they are doing their computer skills, they should be trained. And once they are brought into an institute or a hospital, they should be then trained into the HMS of that hospital into a great extent.
That is the EHR.
Yeah, so that it should be done very, very well. And we have also at Tata Medical Center, few things that the speakers discussed. We have introduced a lot of things like when you take an appointment for the new cases, they can email all their old documents and images to one place, and the summary is made and produced on the day when they come to see the specialist. And as far as the nursing is concerned, to use the technology and to avoid errors, we have created something called COW, computers on wheel. So we
Yes,
have a
yes,
small trolley on which we have a laptop and a printer, which is a barcode printer. So this is allotted
exactly.
in each bay of 6 beds. So the nurse can stand next to the patient and enter the things
Absolutely.
there and there, so that she does not have to mix up and come to the nursing station and do it. Secondly, it is very helpful also in sample collection. You collect the sample, create the barcode, and apply it there itself. So these cows that we are using,
Absolutely.
computers on wheel, we are using them 1 per 6 beds, and every nurse is trained in that. And when we get our staff, we train them in our induction into the use of the HMS. So most of the things like the indenting of the medicines, indenting of the consumables, the indenting of the diet, indenting of the blood and the blood components, all is done online by the nurses themselves. And that comes to a very great
Absolutely.
help to all of us. We shall now
Yes.
move ahead. We are falling short of time. So I'll request Dr. Samratrao to give his views on education of the paramedics. Dr. Samratrao, are you there? Can we hear? Hello, Dr. Samratrao.
I don't think he's there.
Okay, we'll wait. Maybe he'll join again. Dr. Rahul, are you there? Dr. Rahul Singh?
Yes, sir, I'm here.
Yeah, so let us hear from you in the next 10 minutes as to what you have to say. And sorry if you had to wait, though your number was high at first, but we waited till we go on the basics because the air ambulance is something very, very new, but it is something very, very important for those who have to go to specific areas and to reach out to for special treatments available at few centers. So let us hear from you.
Yes, sir. So if I'm allowed, I can share the screen.
Yeah, please. But we'll request you to restrict to 10 minutes.
Sure, sir. Can you see my screen?
Yeah.
Great. Okay. So just a brief introduction. I'm Dr. Rahul Singh Sardar. I'm an anesthetist, intensivist. I'm also the co-founder and director of ICAT Air Ambulance Service, ICAT Foundation, and FEM Education for Flying Doctors and Paramedics. That ambulance is co-owned by me and Dr. Shalini. Both of us are similarly trained and experienced in UK. We're there in UK for 14 years. We've started the air ambulance service in 2017 with just 2 of us as doctors and 1 paramedic. Now we have a robust team of 25 doctors, 12 paramedics, 10 perfusionists, and a big administrative and operating staff. And we are technically Asia's largest air ambulance service at this point in time. As you rightly said, sir, when we came from UK to India, we were surprised to see that there was no regulatory body overseeing the training or the functioning of paramedics in India. The concept of paramedics was completely different from what we understood in UK. There was a lot of dependency on paramedics in UK to do a lot of tasks, especially in the pre-hospital sector and the emergency helicopter sector. Here it was lacking, and now we have multiple teams where the paramedics are the backbone of our organization. We have paramedics in all our teams, and they play a very vital role. They are not only in a supportive role, but doctor and paramedic work as a team in our organization. we were part of the International Advisory Board for the Ministry of State for Health in Delhi. We did highlight this issue, but I think things are working for the better. And in terms of regularizing the training of the paramedics, just a very, very brief story about us. We came here in 2017, we established ICAT, and we are into inter-ICU patient transfers, organ transfers, and ultra-critical care patient transfers requiring ECMO. We use multiple types of aircraft, including twin-engine jets and twin-engine turboprops, single-engine turboprops, and also helicopters. This says a story from the concept of air ambulance, a robust air ambulance service that we thought about in UK, and then we put into practice the systems that we learned there in here, and we are expanding rapidly. But the backbone of, as I said, the backbone was the training part. We launched fellowship in aeromedical sciences and diploma in aeromedical sciences. Fellowship is for the doctors, diploma is for the paramedics. We conceptualized this training program based on the need that we needed our doctors and paramedics to have here in India. We finished our first batch of training. 12 doctors and 15 paramedics were trained through a one-year training program, which went through 4 different modules. The faculty, the syllabus is written in London HEMS. The faculty comes from UK and trains them. We train them as teams. We don't train them separately. So they are facing a scenario as a team, as a doctor and a paramedic team. A paramedic is responsible for certain things. The doctor is focused on the patient, whereas the paramedic is focused on everything else, the whole surrounding, and a paramedic plays a very important part in the whole operation. And this is just a few more visuals. Just briefly trying to make you all understand what are the different types of air ambulances. We have fixed wing air ambulance, which is an 8-seater plane with a stretcher, which has a stretcher and 4 seats, and a helicopter, which can take 1 patient at a time and 3 medical staff. Rotary wing means helicopter. They have certain limitations. In India, we cannot fly in bad weather. We cannot fly in the night. Most of the rooftop helipads are non-functional, and it has major advantages in terms of usage. It is used in emergencies, and obviously it is irreplaceable during a national disaster. We were involved very heavily during the floods in Kerala in 2018. We had 1 helicopter which we relocated to Chenganur, and this I'm putting here the slide to highlight the technology that we used. We were used to a medical emergency scoring system called Muse in UK when we were doing critical care outreach, and that is the same system we adopted for a national disaster here in India. We covered 500 relief camps from our base in Chenganur. Those 500 relief camps were manned by paramedics and non-clinical doctors from pathology and microbiology background. We made the system so easy for them to operate that they could follow the Muse and they could flag up critical patients or deteriorating patients, which were flagged up in our morning, afternoon, and evening virtual rounds that we used to have on WhatsApp video calls. And the deteriorating patients were managed on site by these paramedics, advised by us, and then the ones who were further deteriorating were airlifted by us, by the doctor and paramedic team. I would not like to go into further detail because of the shortage of time. Definitive care is the one which actually determines whether the patient is alive or not, giving an example of the deaths on the road traffic accidents. I'm just giving an example of an accident happening on the Delhi-Jaipur highway. That at this point of time on the national highway, the ambulance response, you are facing minor injuries, critical patients, or dead on arrival. The paramedics do a scoop and run operation. They either take the patient to a catchment area hospital, which is not designed or staffed enough to carry out level 1 trauma care, which is actually the definitive care. So therefore, a secondary road transfer happens either to Delhi or to Jaipur, And that is where we are losing a lot of lives. What we want to bring in is this example where the same accident happens, the same kind of patient is responded to, but this time the land ambulance paramedic is empowered with further training into the first response, as well as has the support of technology. We use a scoring system called the MIST scoring system. MIST stands for mechanism of injury, injury sustained, vital signs, and time to the nearest trauma center. This is a drop-down. They can be, it can be operated by anyone, even a very junior paramedic can do this. It's an app-based thing, and a MIST score is beyond a certain threshold. It is immediately highlighted to the command center. The command center then initiates a HEMS response. A helicopter is deployed for a patient who has the potential to survive this injury, and the helicopter then has the doctor and the paramedic fully trained, and they can perform a list of procedures, life-saving maneuvers on site, and then they can fly either to Delhi or Jaipur to a level 1 trauma center. The innumerable studies shows the advantage of helicopter-based emergency response to a ground ambulance emergency response. Again, I would not like to go into further detail on that. Just one important point: India ranks 1 in the number of road traffic deaths in the world. We are the top. And in the whole of the G20 countries, we are the only one without the helicopter-based emergency response system. All the 19 of the G20 countries have HEMS. We do not have HEMS. A helicopter to be operationally ready needs a doctor and a paramedic to be on standby with the helicopter. The DGCA rules, again, we were involved in drafting the civil aviation required document, can authorize the helicopter to be deployed within 5 minutes of getting a call. Now we have set up our base in Calcutta. We are predominantly a South India-based organization. We are based in Hyderabad, Bangalore, Chennai. But last month we have set up a base in Calcutta with our fixed-wing aircraft. The plan is to set up helicopter base also in Calcutta and also in Guwahati, not only reach out to all the neighboring states here in around West Bengal, but also the 7 northeastern states with the same concept of emergency response, not only for trauma, but for the medical emergencies. Coming to fixed-wing aircraft has certain advantages. It is fast, it can be flown between airports, and it is primarily under the domain of critical care. We transfer one patient from one IC to another, and we are the only organization who does both, helicopter as well as fixed wing. This shows a range of the fixed wing aircraft. Now that aircraft, which is now based in Calcutta, it can cover the whole of the northeastern states as well as the neighboring states of Bengal. Response time will be less than 2 hours. Again, it is based on technology. We are getting heavily into tele-ICU, as well as we are keeping around 10 fully trained paramedics and doctors on site in Calcutta for an immediate response. Not only these states, but we can also respond to Bangladesh, Myanmar, and from our South Indian bases, we can respond to Sri Lanka as well.
Can we
just a brief? Sorry, sir. Please go on.
Yeah, we have some clarifications now. It's a very intriguing information that you have given us, since it is something new, and many a times it is important to take help of the air ambulance. I have some basic questions. Number one, you've shown these 2 sectors, so you fly only in these 2 sectors, or you can go beyond that also?
No, sir. We are flying pan-India.
Okay.
We have placed our own aircraft, one in Calcutta, one in Chennai. And for the rest of the India, we fly from either the South Indian aircraft, depending on where the patient is going to eventually. And or if it's a North India-based operation, we use a locally available aircraft over there. But we use the same teams.
And as you said, the response rate is about 2 to 3.5 hours.
For a fixed wing, sir.
Fixed wing. And okay. And otherwise, for the smaller ones, it may be less time. Yeah.
The helicopter. Yes, please.
Now, does your team check the patient before taking or committing?
Yes, so the principle that we work on is a bed-to-bed service where we fly the doctor and the paramedic a night before to the pickup location by commercial airlines. So the doctor and paramedic go to the referring ICU. We get involved in pre-optimizing the patient overnight, and then the aircraft comes, and the same doctor and paramedic will take the patient from the ICU, go to the airport, load the patient, and then fly to the destination. And we do a
And
bedside handover.
is this also available for unnatural sites? Say for a accident or a hill station, or is there available where even those remote areas where the chopper cannot land? Do you have facilities of airlifting a casualty in a remote area?
So we were facing a possibility of going down the winching route winching patients up on the helicopter without landing. But at this point of time, neither the pilots that we are using in the helicopter nor our staff are trained on winching. But that is definitely one in the future.
Actually, most of the methods that we just discussed have been being used in the army ever since for casualty evacuation, because we have our casualties at various areas. It may be in the desert, it may be in the snow, it may be in the heights, it may be in the jungles. So we've always devised various methods of evacuating those casualties, and some of them do require air evacuation where the helicopter cannot land, and there also we use special these stretchers to airlift the patient and then transport. That is something which would be required, especially in case of accidents, for saving the patients and taking them to the hospitals. I have two more questions. One may be a little sensitive. I do not know whether you would like to answer, but still for the information of all of us, what does is the approximate cost of an average airlift?
So the helicopter service that we are offering, we want to make it free for the people, for the victims that we will be responding to. We have worked out a financial model which will not burden neither the government nor the hospitals for that. And for the fixed wing operations, which is operating between ICUs, the patients do have to pay for the for the service. Usually, the air ambulance service is definitely a costly affair. Yes, and the whole point about us having multiple bases, keeping a locally available aircraft, is to reduce the flying time. The flying time is the biggest contributor to the actual bill.
True. No, because if it is a unquotable amount, it's there. But if you can give us some rough idea as to what it would be, it would be nice for.
Correct. So earlier, a patient from Guwahati to Calcutta would have costed more than 10 lakhs because the aircraft would either come from Delhi or from Bombay. Now it will cost less than 4 lakhs.
4 to 5 lakhs. Okay.
Less than that. Less than 4 lakhs.
Okay. No, that's not a very unimaginable cost, and definitely lesser than what I was expecting from you. Now, another question: is this covered by any insurance? Is this covered, the airlifting? Is it covered by any of the medical insurances that we have prevalent at present in the country?
The medical insurances for the high-end premium payers, there is a provision for air ambulance, but the amount that is set aside for air ambulance is very small compared to the realistic value. Secondly, the fine print of the insurance says that only if those specialties are not available in that area, only then the insurance company will pay for the air ambulance. And technically, you have neurosurgeons every nook and corner of India, whether there is a neurosurgeon on or not, as you can imagine. So on paper, they will fail to get an insurance cover for an air ambulance. But most of the international patient transfers are completely insured.
international insured, but in your experience, you have not seen any Indian insurance company paying you up for any transfers that you have made or air lifting that you have done.
Yes. All the international transfers were insured, or none of the domestic transfers were insured.
Okay. And do you feel that in the near future, will this become a little more affordable and approachable for the common man, where we can do it, especially for the critical injuries or even for critical conditions from smaller towns where the patient can be shifted to bigger areas? Though nowadays,
Yes,
super specialties, hospitals are coming up everywhere. AIMS is coming up in so many places. Super specialty hospitals from the chains, from the bigger chains, Apollos, etc., are in many areas. So maybe the flying time is less. Only thing is you will need that kind of aircraft which can afford to have a space for a ventilator and for 4 people to transport a critical patient.
Absolutely correct. So basically the ethos of an emergency response by helicopter should not even give you time to confirm whether the patient is insured or not, nor the paying capacity of the patient. Within 5 minutes, if you are supposed to fly, if you take off within 5 minutes, it's impossible to assume that the patient is injured or has a paying capacity. So we are going to assume blanket cover, like we did in Kerala, like that we should be having that kind of blanket cover within a state. That given a certain clinical criteria, the patient, if it requires a highly trained team to be airlifted to the spot or to airlifted to a village where they can perform a life-saving maneuver, and then package that patient and bring them to a tertiary center, then the payment thought should not come in the clinician's mind. So the
thank you very much. Thank you very much, and compliments for the good work you did in the humanitarian work in Kerala, and all the best for this thing, which is the need of the hour. And I would request you to let us know your contact numbers or anything, so that we, if any time we need in the hospital for a patient, we can contact and let us know. I can see Dr. Samratrao. Are you back?
Yeah, my internet had dropped. I'm sorry.
Yeah. So anyway, we are running short. We are almost at the end of the time. So in short, if you could tell us your views before we end up.
Okay, so I had made a presentation, but I'm not using that. So I think technology, if in the near, as of now and in the near future, it will get really common amongst use with paramedics. So they have to be trained from the student life about how to be able to approach to use this technology to communicate in between themselves and the hospital when they're en route with the patient, and also how to talk and communicate with patients and patients' relatives, because once they see that everything is being done online on the machines, obviously they will have a lot of queries. And along with this, for the paramedics, we can introduce simulation games, or we can introduce serious games and hands-on training with the interface with mock patient scenarios, where they can interact with the device. And let's say they have gone to receive a patient that has had a stroke, to how to assess the airway and how to see whether the patient, it's a convulsion or a stroke. So we can create interactive games that generate points and help them in their education, and also assess and reassess the ability to use technological platforms to be able to correctly guide and diagnose patients. And other thing I think that is of important is emergency call and dispatch, like the 911 service in the US, where specially trained call centers can direct and redirect ambulances based on situations, and also direct them to specialized centers, so that time is not wasted in going from one specialized center to the other.
Thank you, Dr. Roy. Yes, thank you very much, Dr. Roy. I'll just go back to the last speaker, previous speaker, Dr. Rahul. We have one question from you, which I could also answer, but I thought I will have it from you only. Dr. Rahul, can you hear me?
Yes, sir, I can hear you.
Yeah. Now, any specific contraindications for air transport in terms of any pneumothorax, in terms of head injuries, or will your fixed wings take all the patients?
That is a very, very relevant and a very important question, because that's a big misconception that, about air ambulances. The type of aircraft that we use they have pressurized cabins. So no matter what altitude they fly in, we can reduce the pressure inside the cabin to almost sea level or up to 4,000 feet, depending on what the condition of the patient is. So therefore, a pneumomediastinum or a pneumothorax will not deteriorate in transit.
Yes.
Obviously.
Yeah.
So there is absolutely no contract.
Yeah. Thank you very much. And it was a wonderful interaction. And I would just like to sum it up, saying that the need of the hour is to increase the paramedicals and to train them and make them adapt to the innovative equipments that we have, to make them tech savvy, use of apps, use of technology, and to create data, retrieve data, store data, and analyze data. Another important thing is that we must try to train everybody, from children to the adult, from school level to workplace and in community, in first aid and in giving help to each other. The simulation is something very good. Constant training is very important. Doing recurrent training, doing mock drills of disaster management and various other such SOPs of a hospital are also very important. And one of the means of increasing the volume of these paramedicals is that every hospital should come in and try to train, even if we train two paramedicals in each of our departments. Every year we'll take out 50 paramedicals, and the government should come out and give this authority to the institutes and this licensing to train the people. So on this behalf, I would like to thank the organizers for giving us this opportunity to discuss this pertinent issue, and all the speakers for participating. Thank you very much.
Thank you, sirs and madam. It was a very enlightening, session for us, and working with you has been a very, the experience has been very enriching for us. So we close this session here. So the next session will start at 4:45 IST, and it will, we'll have doctors sharing technology advancements in healthcare. So this session we will close with a video of one of our partners. Thank you.
Thank you, madam.
Thank you.
Hello, it's a magical feeling when you know you're healing. We are here beside you. Hold me, tell me all you want to. We can get you through all of this trouble. We will wash away the pain you're suffering and make you well. We serve from our hearts, we serve with a smile. Service with a smile, service with a smile. Hello, you know how much we care. Trust us, we will be there, always right beside you. Life has sickness that can get you. We can get you cured, wipe all your tears. We will wash away the pain you're suffering and make you well. We serve from our hearts, we serve with a smile. Service with a smile, service with a smile. Hello, it's It's a magical feeling when you know you're healing. We are here beside you.